Picture the human heart for a second. It's essentially this highly secure, heavily guarded fortress, right? Day in and day out, it's just pumping life-giving blood without missing a single beat, and its inner walls are completely sealed off from the outside world. But what happens when microscopic invaders actually manage to breach those gates and set up camp right inside the heart's inner sanctum? Well, welcome to this explainer on infective endocarditis. Today, we're going to dive deep into exactly how the body's ultimate stronghold can fall to the tiniest of enemies.
All right, here's our roadmap for today. First up, the anatomy of an invasion. Second, we'll meet the culprits. Third, we look at the collateral damage. Fourth, the diagnosis. And finally, treatment and prevention.
Let's jump right into Section 1, Anatomy of an Invasion, targeting the heart.
Okay, so what exactly are we dealing with here? Infective endocarditis, or IE, is an inflammation of the endocardium. Now, as you know, the endocardium is that simple squamous epithelial tissue, basically the ultra-smooth inner wallpaper that lines the inside of your heart chambers. But the real primary battleground here, the spot where the sheer destruction happens, is on the delicate heart valves that are coated by this exact same tissue.
For this disease to really take hold, it requires what is literally a four-step perfect storm. Step 1 is valve damage. Something like rheumatic heart disease, or even just having a prosthetic valve, strips away that protective endocardium and it exposes the super sticky collagen underneath. Step 2, a platelet and fibrin plug forms right over that damage. We call this sterile clot a non-bacterial thrombotic endocarditis, or NBTE. Step 3 is bacteremia. Somehow pathogens have to actually enter the bloodstream. And finally, step 4, those circulating pathogens find that sticky NBTE plug, they anchor themselves down, and they start growing into this massive, highly destructive microbial vegetation.
Now, we typically classify the pace of this whole invasion into two distinct camps. First, you've got acute IE. Think of this as a rapid biological blitzkrieg. It's driven by highly virulent pathogens like Staph aureus. These patients look incredibly sick, they're septic, and they suffer super rapid valve destruction. On the flip side, we have subacute IE. This is much more of a stealthy, indolent infiltration by lower virulence bugs like strep viridans. The symptoms here are kind of vague, maybe just a low-grade fever or some fatigue, which honestly makes it a much slower, sneakier threat to catch.
Moving on to Section 2, Meet the culprits, the bacterial invaders responsible for actually breaking into the bloodstream.
So remember that whole perfect storm we just talked about? The rule that you absolutely need a damaged valve for the bacteria to stick to? Well, actually, scratch that. There is one massive exception to that rule, and it's Staphylococcus aureus. This bug is just so virulent, so unapologetically aggressive, that it doesn't even need a pre-existing valve injury. It doesn't need that sterile platelet plug to launch its attack. It can literally latch onto and destroy a perfectly healthy, totally undamaged native heart valve all on its own. It's wild.
As for the rest of the gang, they each have their own preferred entry points. Staph aureus usually gets in through skin breaks, IV drug use, or catheters. Strep viridans is just part of your mouth's normal flora, meaning even a mundane dental procedure can let it slip right into your blood. Enterococcus breaches the walls through UTIs or genitourinary procedures. Strep galliticus is uniquely tied to colorectal cancer, so if a patient's blood culture grows this, you literally immediately go looking for a tumor in the colon. And finally, Staph epidermidis. This one lives on the skin and absolutely loves sticking to prosthetic hardware, like pacemakers or artificial valves.
Section 3, Collateral damage and complications. Because as you'll see, the fallout from this localized infection is truly catastrophic for the whole body.
Once they're in, the disease destroys the host through a brutal three-pronged attack. First up is local valve destruction. The bacteria, and your own immune cells, by the way, release proteases that literally chew the valve apart. This leads to acute heart failure, severe regurgitation murmurs, and deep tissue abscesses. Second is septic emboli. I want you to think of these as biological shrapnel. Chunks of the infected vegetation just break off and shoot out into the bloodstream. And third, immune complexes. Your immune system churns out antibodies to bind the bacteria, but these chaotic clusters end up depositing into delicate tissues all over the body, totally clogging them up.
And the horrific geography of this biological shrapnel depends entirely on where the vegetation is based in the heart. If the bacteria set up camp on the right side, the emboli are pumped straight into the lungs, which means you're looking at pulmonary embolisms and lung abscesses. But if the vegetation is on the left side of the heart, so the mitral or aortic valves, that infected shrapnel gets fired out into the systemic circulation. That causes devastating strokes in the brain or massive infarcts in organs like the spleen and kidneys.
Now, speaking of the right side of the heart,
Left-sided infections are generally way more common, but there is a very specific, super high-yield exception. IV drug users who introduce Staph aureus through dirty needles overwhelmingly see infections on the right-sided tricuspid valve. A really great memory trick for this is the phrase, "try to stop doing drugs." The try reminds us of the tricuspid valve targeting that we see in IV drug abuse.
So all this internal chaos actually leaves physical clues on the outside of the patient's body, and we split these into painless and painful signs. Those septic emboli, they cause tiny painless bleeding spots called Janeway lesions on the palms and soles, or dark red lines under the nails that we call splinter hemorrhages. But those immune complexes we mentioned earlier, when they deposit into the delicate pads of the fingers, they form Osler's nodes. And the absolute key here is the classic trick. Osler, ouch. Osler's nodes are highly, highly painful.
So, with the valves dissolving, biological shrapnel flying everywhere, and immune complexes clogging up the kidneys, the urgent question is, how do we actually catch these culprits before the fortress completely falls? Which brings us right into Section 4, Diagnosis, the detective work.
To catch this killer, doctors rely on a very specific detective's toolkit. You have to visualize the physical damage, and you have to identify the invisible bacteria. While a standard chest ultrasound is a decent start, the absolute gold standard here is the transesophageal echocardiogram, or TEE. By putting the ultrasound probe down the esophagus, directly behind the heart, doctors get the ultimate unobstructed visual of those hidden vegetations and abscesses. You pair that visual evidence with 3 distinct sets of blood cultures drawn from the patient to conclusively prove the bacteria is in fact in the bloodstream. Then doctors chunk all these clues together using the modified Duke's criteria to make an official diagnosis. Just think of them as major and minor puzzle pieces. The major clues are a positive echo showing a vegetation and 2 positive blood cultures for those typical pathogens. The minor clues include things like a fever over 38 degrees Celsius, a predisposing heart condition or IV drug history, and evidence of those emboli or immune phenomena, like the painless Janeway lesions or the painful Osler's nodes. To get a confirmed diagnosis, you need either 2 major clues or 1 major and 3 minor clues.
And finally, Section 5, Treatment and Prevention, Medical Counterattack.
Let's walk through the exact timeline of this chemical warfare because it matters. Time 0 is absolutely critical. You must draw those 3 sets of blood cultures before blindly firing any medications. If you give antibiotics first, you might mask the bacteria and literally never figure out what you're fighting. Immediately after drawing the blood, you hit them with empiric antibiotics. We're talking a broad-spectrum, heavy-hitting combo here, like vancomycin plus a beta-lactam, just to cover the deadliest bugs right out of the gate. Then, days later, when the specific culture results come back from the lab, you can tailor and narrow your antibiotic spectrum to act like a sniper rifle against that exact pathogen.
But what happens when the antibiotics just aren't cutting it? When the physical fortress wall is so chewed up that chemicals can't save it, you have to call in cardiothoracic surgery. The absolute breaking points where surgery becomes mandatory include acute left-sided heart failure or cardiogenic shock. Another huge one is prosthetic valve dehiscence, which is the truly terrifying scenario where an artificial valve literally tears away from the heart wall. You also look for the formation of deep perivalvular abscesses, recurrent septic emboli shooting into the brain even though the patient is on antibiotics, or if the patient is infected with a highly resistant fungal pathogen like Candida.
Obviously, the best way to win a war is to never let the enemy inside in the first place. We do this by fortifying the gates through prophylaxis. It's a really simple 3-step preventative protocol. First, identify high-risk patients. This is anyone with a prosthetic valve, a history of previous infective endocarditis, specific congenital defects, or a heart transplant. Second, identify risky procedures. And yes, this absolutely includes things as mundane as a routine dental cleaning or a root canal, or a respiratory incision. Finally, you intercept that natural oral flora at the gates by giving the patient a dose of oral amoxicillin 30 to 60 minutes right before the procedure.
So, we've mapped out the anatomy of the invasion, identified the microbial culprits, witnessed the collateral damage, and learned exactly how modern medicine mounts a life-saving defense. But I really want to leave you with this provocative thought. We love to think of the heart as this impenetrable, mechanical fortress, but given how incredibly delicate the balance truly is, are your own bodily gates secure enough to withstand the microscopic, invisible threats that are already living comfortably inside your mouth and on your skin right this very moment? Thank you so much for joining me on this Explanaire. Keep learning, keep questioning, and I'll catch you next time.